Yeah, good evening everyone. I am Dr. Om J. Lakhani and thank you for a wonderful talk. And I think I have to follow this up with now from diagnosis and classifications, we are moving to therapeutics. So I thought this was supposed to be a school and school is supposed to be interactive. So I think those at the back, this is going to be completely interactive, okay? You'll be asked questions. If you need a coffee, there's one right outside. I suggest you grab one. Right, because I'm going to ask you questions. So, again, if you're at the back, I suggest you come in the front so that we can be more interactive. Okay, so we are going to talk about insulin therapy. Again, like a school, like an ideal school, we'll be having a lot of, a couple of cases. Most of these cases are sort of real life cases. So again, try to find a mic near you because like I said, we'll be asking questions. So, we'll hope you'll answer that. Okay, so let's begin. Many of you are in the WhatsApp group, so we have put a link there. You can just check out that link on the WhatsApp group. You can use this here also. Yeah, you can just use this QR code. You will be able to access some additional notes, right? There'll be some research articles. Very importantly, there'll be certain mini applications. Remember, insulin a lot of it is mathematics. So you'll be able to access those data as well. So you can try to use this. The same thing is there on the WhatsApp group also. Okay. So, and I'm very sure that at the end of the presentation also you'll be able to access this more or less in perpetuity. So you'll be I hope it'll be useful to you in the upcoming times in your practice as well. Right. So this is what it will look like, right? And you can when you access this, right now. Before we begin, yeah, okay. So this is the outline of the talk. So this is what we are going to discuss in the next 43 minutes. When to initiate insulin, what are the types of insulin and different insulin regimes, how to titrate the insulin, how to inject the insulin, and storage and transportation. A lot of it is basic. I'm sure you're all used insulin in your life, but what we're going to do is we're going to talk about the nuances of that and mainly how to apply that knowledge in your clinical practice. Now, I'm a very firm believer of a very unique way of learning, and that's there on our, the platform also, the link of which I've shared, and that's called the Vedantic model of learning, where knowledge actually transcends into 3 stages. Okay, so one is this, right, where you learn imbibe the knowledge. And then there is what is known as manan, where you reflect on the things you learned, right? So that's a very important aspect of knowledge, right? So reflection is very important. So I think if you're making notes, if you're taking notes, or if you're taking pictures, go home and reflect on what you learned, right? So that you will learn better. And the third part is what is known as nidhi asan, basically using what you learned in your practice, right? So on Monday when you go back to your own clinics, a few things what you learned in the entire session, right? I hope you start applying that in your practice. And that is what solidifies medical knowledge most, right? So if you follow these 3 steps. So let's begin with the first situation, when to initiate insulin, right? So what are the situations where patients always need insulin, okay? Or more or less always need insulin? Type 1 diabetes, I'm sure you'll agree, right? A type 1 diabetics will always need insulin. A patient presenting with diabetic ketoacidosis. Now, when a patient presents with diabetic ketoacidosis, we don't know whether it's type 1, it's a ketosis prone type 2, we don't know, right? So, well, more or less, patient would need insulin. Diabetes in pregnancy, well, there is some role of metformin, I don't want to go to controversy of that, right? But more or less, you'll need insulin. Pancreatic diabetes, type 3C diabetes, right, would need insulin. Perioperative patients, right, patients undergoing surgery, right, more or less will need insulin. Generally in hospital patients, we start them on insulin. And patient with often other organ involvement, maybe end-stage renal disease or end-stage liver disease, again will need insulin. Right? So these are the patients where insulin is more or less, I'm sure you'd all agree that the patient needs insulin, right? Most of these situations. The problem really lies in that type 2 diabetic patients, when do you start insulin? That's the part which is most contentious, and that's the part which is most applicable to our clinical practice also, because you're going to see these patients day in, day out in your practice. So what type 2 diabetes patients need insulin, and that is what we're going to discuss. So let's start with a case. Okay, so this is a 30-year-old. A lot of these cases I'm going to show are real patients. Okay, real patients who actually came in with. So real patients have real problems. Okay, we have, as doctors we face real situations, right? So this is a 30-year-old male patient, lives in the US, came to India on a family vacation. He then started having, so he was there for a longish vacation, staycation kind of situation. He started having unintentional weight loss, polyuria, polydipsia, and then, his aunt was a pediatrician. This is an adult male, right? But aunt was a pediatrician. She immediately recognized that, okay, these are signs of diabetes, right? So, she asked for some checkup. His father already has type 2 diabetes, which was diagnosed when he was 47, and this guy has a BMI of 27, okay? Now, this is where they immediately, they came this is again, 2022 case, right? So these are the reports, right? So like I said, the aunt is a pediatrician, and aunt said, okay, now this is, boy, you have diabetes, right? And she gets this test done, and you can see the random sugar, the fasting sugar is 400, the postprandials are also very high, HbA1c is 13, creat is 1, other things, LDL 196 very high, triglycerides are very high, SGPT is high, TSH is more or less normal. Interestingly, and this is where we looked at, you have these things, but the patient does not have ketosis or ketoacidosis. Patient walked into the clinic with very high sugars, but no ketosis. Okay, so yeah, so okay, let's pause here, right? Let's take this case here. Okay, I'm sure you'd say that it's very obvious that the patient you're going to land up with patient requiring insulin for sure. But when this patient comes to you, what do you think this is, right? Again, I already gave up that this is type 2, but let's say you don't know anything about this case. The patient just walks into you, right? The aunt is a pediatrician, and the patient comes to you. Type 1, type 2. How many of you think it's possibly type 1 diabetes? Yeah. Okay, why not? Why is this type 2 and not type 1? Okay, but how age? Because now, I'll tell you, my youngest type 2 diabetic is 11, and my oldest type 1 diabetics is 84, right? Newly diagnosed. So age is just a number, right? Okay, anything else? Okay, BMI is 27. But I'm sure you all have seen obese type 1s as well, right? Of course, not, if they, yeah. Family history of type 2, yes, okay.
Metabolic syndrome like the triglyceride and LDL also high.
Okay, yeah, correct, okay, that's point in favor. Anything else? Absence of ketosis, right? So I think, one red flag which immediately kind of puts you in that, well, patient has a blood sugar of 400, yet no ketosis. Okay, again, that's one point very strongly against the type 1, right? It's anybody's game here, right? It could be anything, right? But let's kind of argue these things out, right? So this is one point, and that's the point where this specifically I highlighted, right? That the patient did not have ketosis. Now, when you have a person with absolute insulin deficiency, very likely, especially a type 1, right? Very likely with a blood sugar of 400 with polyuria, he will develop ketosis, right? It's very unusual that he does not. Not only does he, I'm not saying ketoacidosis, doesn't even have ketosis, okay? So which is again one flag. So in these cases, what we do is we do something called a mixed meal stimulation test. Well, we could very well have done a random C-peptide also, but let's say we did a mixed meal stimulation test. In a mixed meal stimulation test, what we do is we ask the patient to come in the morning fasting. We take a fasting sample, we take a C-peptide along with that, and then we give a standardized liquid meal, right? Internationally, it's Sustekal. In India, we use Ensure powder, which is similar composition. And after 90 minutes, we take a sample again, and we check the C-peptide again, okay? So this is what we did in this patient, okay? And we also looked at the antibodies, so GAD65, IA2, and all that. So these are the results, okay? So the patient's fasting sugar on the mixed meal was 275. C-peptide was 2.95. Well, I should mention the unit. So it's nanogram per ml. Random sugar, the post-meal sugar is 413, and again the C-peptide is right. Now, as a rule of thumb, okay, again we have some calculators for the mixed meal stimulation also. But as a rule of thumb, what I'll generally suggest to you is that when you see these values less than 1, okay, 1 nanogram per ml, you are probably dealing with, you know, type 1, right, with or absolute insulin deficiency, right? So that's, so if this patient's, you know, fasting blood sugar is 275 and his C peptide was 0.6, I'm thinking type 1, right? So, you know, even with a negative GAD antibody, right? So don't always rely on the antibodies, right? So that's, be careful, right? What if it was the other way around? Let's say patient's insulin production is fine, right? It's not deficient, but his GAD antibody is positive. How do you classify that? Anybody? So a patient comes to you, same patient, right? Only thing is what we changed in the reports is that the C peptide now is fine, like what we have. The only change is, let's say his GAD is positive. What is that classified? He's 30-year-old. Correct. Late onset rather, right? Yeah, yeah. So that's the artist formerly known as LADA, right? Which is now, basically LADA is a slowly progressing type 1 diabetes. That's what it is, right? So it's a type 1 only, but it progresses so slowly that the patient doesn't become insulin deficient for a while, right? So if the GAD antibody then here was positive, then that's what is actually the definition of LADA, right? That's what the LADA actually is. The only thing is, you know, maybe the patient didn't need insulin for 6 months and all that. These are technicalities. But the point is you have autoimmunity positive with preserved beta cell. That's LADA, okay? So it's a type 1 which is very slow. That's what it is, okay? So moving on. So here we have this, you know, on the platform, you can see we have these kind of little mini applications, right? So you can try it out. Does my patient need insulin? Okay. In fact, we made some time back, you know, we had an app called Centurion Insulin app. We actually put this into the system. The idea was, we often see in clinical practice, a lot of patients who need insulin, you know, who come to us, but they have not been started on insulin by the physicians. You know, it's very sad, right? So that's the whole point, you know. So we have this kind of application. You know, you can try it out. You can put in the key in the data, right? So in this particular situation, you know, obviously this case it's very obvious that the patient needs insulin, but you know, that's the thing, right? So what we finally diagnosed based on this is that this patient has type 2 diabetes with severe hyperglycemia. That is what the patient has. But then comes the million dollar question: does he need insulin? Okay. Now, how many of you are going to prescribe insulin to him? Yeah? Okay. How many are not going to prescribe insulin to him? Why not, sir? Yes. Okay. Fair argument. Okay. Another fair argument. Okay. Any other arguments of not giving insulin? So that's why these cases are important, right? These cases are, very fact that these cases are important because this is what the exact argument will be, okay? Any arguments, any other arguments against giving insulin? Okay, any arguments for giving insulin?
Because the patient has a sign of leukotoxicity and giving insulin will have to recover beta.
Can we have some mics? Yeah. Mic है तो option एक पे. Hand mics. Yeah, please.
Because the patient has a sign of leukotoxicity and early giving insulin relief from them and also preserve the beta cell function.
Okay, excellent point, right? So patient has glucotoxicity, and when you give insulin to these patients, you can actually preserve the beta cell, right? That's very, very valid. In fact, excellent argument. There's no, you know, beating this. Any other arguments, right? What are the signs of glucotoxicity in this patient? Right, correct, right? So the patient has osmotic symptoms, okay? Patient has osmotic symptoms. Osmotic symptoms being polyuria, polydipsia, weight loss, unintentional weight loss, which this patient had, visual blurring, okay? Patient is going to be miserable for sure. If you are this patient, you are miserable, okay? With a big M, okay? The very reason why, and I agree that patient may not agree, right? That those are arguments which are always valid. Human arguments are always there. But if you talk about from a physiological perspective, and I think he nailed it, two very essential points here. One is the fact that patient has osmotic symptoms. So when you have a patient presenting with osmotic symptoms, it's always better to start the patient on insulin. Having said that, the physiological argument is that like he very rightly said, now there are studies for this also, and there are smaller studies. A lot of these studies actually come from, these may not be always true for Caucasians, but for Asian patients, and there are very, studies done from China and India, that when you give insulin to this patient, it gives rest to the beta cell, leading to preservation of beta cell, right? Remember, and this is a very important fundamental process, right? In fact, I was reading some very interesting similar discussion on Twitter by one of my endocrinologist friend. The thing about diabetes management, and think about, since we are in this diabetes management conference, always think long term. Never think short term, right? Think about how the patient is going to be, right, 10 years from now, right? We just had a talk on microvascular complications, right? Remember, this patient is not going to conk off or die, right? We'll not allow that to happen. But what we are thinking about for a 30-year-old with a type 2 diabetes is what's going to happen to him when he's 40? What's going to happen to him when he's 50? Right? What will happen to him? What will happen to his beta cells? What will happen to his cardiovascular risk? Right? What will happen to other complications which he can develop? Right? So think in a long-term perspective, right? And think in a long-term perspective, do everything at this point of time which can help him on a long-term basis. And the third, again, a human argument, right, here, would be the one treatment which is going to give him the most symptomatic relief, for sure, is going to be insulin. He'll feel better, right? And I think there's no better argument than that, right? Patients come to you for feeling better. Patients don't want to feel worse, right? So the essential argument here would be, again, these points, right? So patient has these symptoms. Again, if you see guidelines also, right? HbA1c guidelines, most guidelines say, including the ADA guideline, that HbA1c more than 10% and random sugars more than 300, you should consider insulin, right? That is there in every guideline. Now, of course, ADA guidelines is more moving towards GLP, but I have this one theory, right? I'll always remember, see, a lot of times, guidelines are fine, guidelines are okay, right? But you're dealing with real life practice, right? And I always have this theory, when your patient comes to you in a catabolic state, right? Always give therapies which will heal that catabolic state. Patient comes to you in an anabolic state, right? Weight gain and everything, give therapies which will reduce that, right? So a patient comes to you with unintentional weight loss. Give him drugs which will help him regain the weight, right? Which will restore that balance, right? Like insulin, maybe even SU. But the problem with SU is that SU cannot be very well titrated, right? There'll be, there are challenges. And once the glucotoxicity breaks, the patients with the same dose of SU will start developing severe hypoglycemias. That's the problem with SUs, right? If this patient is given and this is again what I've seen in practice, and this is disastrous, if this patient is given an SGLT2 or maybe even a GLP, a patient would actually get worse, right? Now, patient is already having polyuria. Yes, the sugars will come down, right? But you're worsening that, right? And the patient then feels more miserable, right? And we don't want our patients to be miserable, right? That's the point, right? So a lot of the times in clinical practice, and we often now with SGLT2 in India being very freely available and being very, cost effective and cheap and available in every corner of the country, a lot of the times we have started getting patients who are having good sugar control, but they are not happy, right? They want to meet you because I am taking this medicine, but I feel worse. Okay, so that is what happens sometimes when you give SGLT to the wrong person. Patient actually feels worse. But if this patient was, 35 kg per meter square with, complaining to you about gaining weight, acanthosis nigricans, I have gained, edema, dyspnea on walking, SGLT2 would be the first choice I'll give, right? Because then that drug will help him feel better. So that's always the, argument, right? Again, there's a school of thought that, precision medicine is ultimately what we want, right? But the precision medicine is always dynamic in nature, right? So when the patient first comes to you, a different set of medicines will work. Maybe in the future, this patient may require some other forms of treatment, right? So this is what the ADA guideline says. I'm not going to do details of that, right? You all know the guidelines in and out of it, right? So we'll then move to case number 2. Any questions? Like I said, it's interactive. Yes, sir. Yeah.
They are doing very well. The symptoms have disappeared. They gain weight and they do fine.
I don't disagree with you, right? Like I said, real life practice is often, different, right? But again, in a very ideal setup, let's say in an ideal situation, let me ask you this: in an ideal situation, right, where you have all the therapies available, patient is ready to, like this patient, aunt was just standing right in it. Whatever you say, he'll take. I'll ensure that, right? Whatever therapy in an ideal situation, cost is not a barrier, other things are not a barrier, and patient's education is not a barrier. What therapy would you give then? Exactly, right? So that's the whole argument, right? So that's the point, right? So what you said is, I don't disagree, right? I agree with you, right? There will be, a lot of the times, but then the argument really comes that if no other things are there, what's an ideal treatment, right? That's the point. We don't know. No, we don't know about exhaustion, right? That's a debatable area. There used to be a school of thought. Maybe the older generation beta cell had some exhaustion things. Maybe giving this patient beta cell, stimulatory therapy, will it exhaust the beta cell? We don't know that. It will not preserve the beta cell for sure. That we know, right? So because you're still using the same system, right? What are the long-term implications of that? We don't know. But in a short-term implication, like I said, what happens is when you give an SU to this patient. You have to keep a very tight control, close watch of the patient because insulin you can always titrate. So let's say we start with 10 units, you can increase to 12, reduce the dose, increase the dose, right? It's a very titrable form of treatment, right? Whereas the problem with SU is that when it's given, right? You have started the patient on 1 milligram, 2 milligram of glimepiride, whatever. Even asking the patient to, go and take 1 milligram if he's already taking 3 milligrams is going to be difficult because what patient will do is, no, I'm having this medicine, I have a stock of this, I'll finish this and I'll take 1 milligram, right? So a lot of the times, and we have seen patients like this, right? Once the glucotoxicity breaks, they start developing severe hypoglycemia. Again, patient getting worse, right? So that's, again, these are things we have to be really, careful about, right? Okay, let's move on to the second case, okay? So 58-year-old male patient, known case of type 2 diabetes since last 8 years, recent worsening of diabetes post-COVID, as you can see, it's an old case. Currently on a glimepiride, 6 milligram, voglibose, metformin, DPP-4 inhibitors, mainly coming to you with neuropathic symptoms. So these are the clinical presentation of this patient. Let's look at the lab results. Okay, so this is the lab result. Fasting blood sugar is 164. Post meal is 293, HbA1c is 9.1, creat is this, LDL is fine, triglyceride is fine, SGPT is little high, TSH is 7.4 and vitamin D is 13. Okay, so these are the reports of this patient, right? So let me just rephrase this. This is the patient, okay? Now this patient is on 1, 2, 3, 4 oral antidiabetic drugs, right? 4 oral antidiabetic drugs and his HbA1c is 9.1, okay? Fine. What would be the treatment you will offer to this patient?
Basal
okay.
insulin.
Basal bolus. So, okay, how many for insulin? Okay, a lot of us are for insulin. How about, again, devil's argument, right? How about SGLT2 trinathicary? Let's put SGLT2. Fair argument. Okay, what about GLP? Patient can afford, right? I heard a lot. Patient comes and says, I heard about this new drug. Life-changing, game-changing. Can I take that? Yeah? Let's say I remove the DPP-4 and put the patient on a GLP. Fair argument? Fair. The problem is, the clinical evidence and a lot of studies have shown that when you have a patient on 3 or more non-insulin based therapies, giving a fourth doesn't have an incremental benefit in terms of HbA1c reduction. At best, it does an HbA1c reduction of 0.2 to 0.4%. And this patient's HbA1c is 9.1, way away from target, right? Adding a fourth drug or a fifth drug or a sixth drug is not going to bring him to the target of 7. That's the essential argument. The only thing which is safe, universally acceptable, easily titrable, where there's no limit to the upper limit of the dose you can give is insulin, right? And perhaps then, right, insulin is the best option in this patient. But you can also see glimepiride of 6 milligram, very often seen in clinical practice, right? At some point, right, remember SU stop working, right? They simply stop working, right? So I have often seen this in practice, again a common mistake, which often happens. You keep increasing the dose of glimepirides like it is insulin, right? And you end up having no benefit for the patient, right? You know, patient starts with 1 milligram, then it's 2 milligram, 3 milligram, and you will, I mean, you know, you'll think I'm crazy, but I've seen a patient on 16 milligram of glimepiride, right? That's the highest I've seen, 16 milligram of glimepiride, right? I really don't understand, right? When it's not working, why keep increasing the doses of, you know, the medicine? So I think that's a little wrong. At this point of time, the only therapy that is really going to be helpful for this patient is going to be insulin, right? Nothing else is really going to give an incremental benefit. And that's why the guidelines, in all their wisdom, both the RSSDI, ESI, and all the other guidelines, typically say that insulin therapy should be considered for all patients failing to achieve glycemic targets with 3 or more oral antidiabetics. Consider initiating insulin with patients with severe hyperglycemia on stable state. This is what the guidelines say. Again, you can put it in the little app that we have, right? Try putting the data and you will get a similar result, okay? Moving on to the case 3. So let's see this patient, okay? 50-year-old patient has acoustic schwannoma, planned for neurosurgery after 1 week, diagnosed to have type 2 diabetes just a month back, okay? I'll move a little quick. I'll try to finish as much as possible. The rest of the materials is there, including the presentation is there on the the link that I gave you, right? So, you know, feel free. I think it's better that we learn a few concepts in detail rather than, you know, try to kind of cover everything, right? So my target is not going to be finishing the course. My target is going to be, you know, giving you as much pearls as possible, okay? So there's a patient with a random sugar of 400, glimepiride, SGLT2, metformin, everything he has. Now, he was uncomfortable with these medicines, so he stopped these medicines on his own, right? Except for glimepiride, which is just that, you know, he's not comfortable with SGLT2, so he stopped it on his own, right? These are the reports of this patient. So, blood sugars, again, real life patient, 288, 356, HbA1c of 9, right? Okay. So, again, you know, I think this is very similar to what we discussed, and I already told you that catabolic state, another very important perioperative thing, right? Guidelines are very clear. Perioperative state, you should stop SGLT2 inhibitors, right? It's a separate discussion in all notes, so I'm not going to go into that, but the point here is that perioperative situation, be careful. Do not take euglycemic ketoacidosis for granted, right? There are a lot of physicians who come and say, oh, I have not seen euglycemic ketoacidosis. I tell them you have missed out. You have missed out. It's very common. I mean, it's not very common, but it's common. The problem is it often goes under the radar. Why? Because blood sugars are normal, right? So you often miss that out, right? We had, I think, at least 6 or 7 euglycemic ketoacidosis being referred to us by cardiothoracic surgery, right? Patient undergoes CABG. Next day, right? First time this came, right? The anesthetist, you know, was looking at the bicarbonate and was looking at acidosis. The patient continued to have metabolic acidosis, which was unexplained, right? And that is when, you know, we came in and we, you know, looked at the patient's prescriptions and other things, and we said, this is euglycemic ketoacidosis. We did the beta hydroxybutyrate, it was high, right? And then the cardiac anesthetist recognized, okay, this is a problem, right? So every time then he starts seeing this type of picture, he starts looking at this situation, right? And there, like I said, you know, they picked up 6 or 7 cases where, you know, in some of the cases there, you know, the SGLT2 was also stopped a couple of days prior also, right? And yet the patient did develop. So again, don't take this for granted. It's a problem, right? I'll say a lot of bashing of SGLT2, right? But be careful, right? It's a very good drug, but has to be used in the right patient, okay? Right. So I think we all agree. These are the take-home messages for the first part. When you have an osmotic symptom, ongoing catabolism, HbA1c of more than 10, RBS of more than 300, pregnancy, ongoing ketosis, HbA1c of more than 8.59 with 3 or more oral antidiabetics, consider giving insulin, right? Patient having other end organ issues, we consider insulin. Okay, moving on. Yeah. Then, of course, you're all aware about the types of insulin, right? I'll not go into much detail, right? These are all types. Now, of course, these days you also have weekly insulins, which are going to come, right? And you're going to have inhaled insulins, which are going to come in the Indian market very soon, right? Very soon. Okay. So these are rapidly acting insulins, and these are short-acting insulins, and these are intermediate-acting insulins, and these are long-acting insulins. Again, for this audience, I'm sure you're all aware, right, of these types of insulin, right? And then you have the weekly insulin, you have the pre-mixed insulin, you have what is known as a co-formulation insulin, and you have inhaled insulin, which is Afrezza. Okay, so these are the things. Based on all these things, there are these regimes which we construct: basal only, pre-mixed, basal bolus, and basal bolus insulin therapy, which is known as multi-dose insulin therapy. So these are the types of ways in which we start the patient on insulin. Most of the time, the therapy we start as a basal insulin. And so basal and basal bolus is what we now maximum use in practice. A lot of premix also is being used even today. We'll see that discussion also. Okay, moving on. So then let's say we have all agreed to the cases of, now remember I'm focusing right now on type 2 diabetes, right? Type 1, it's a different ball game. So you have a type 2 diabetes patient and you have decided that you want to start the patient on insulin. Question is which insulin? Okay. So there is no simple answer. It would also depend on the patient's financial status. It would depend on what insulin is available, right? All the other things, right? A lot of the times, let's say you are working in a government setup or you are working in a setup which has socialized medicine setup, you have only certain types of insulin available to you. What can you do, right? You don't have a choice. So, but let's say again you have problem of plenty, you have all the insulins available, what insulin you will choose in what cases? This is exactly a question which, there's a paper by Dr. Mohan which looked at this, and they started looking at this in a mathematical manner, and they started looking at some formulas which can help you choose whether we can start a premix insulin would be a better choice, or a co-formulation insulin, or would a basal insulin be a better choice. Now if you see international guidelines, and if you take all the insulin making companies, including the ones which make premix insulin, all of them say, oh, basal should be the first choice, which is true for a Caucasian. For an Indian patient, or for a Western diet, right? For an Indian patient or a South Asian patient who are rich in carbohydrates, right? Who are going to take carbohydrates like there's no tomorrow, whether, basal insulin alone works in all of them, that's an argument, which is, very difficult. And that's why in clinical practice also, all of us would agree that all of us have seen premix insulin being used more, even though the guidelines say something else, right? Reality is something else. So this argument, if you put it in mathematical terms, what Dr. Mohan's paper and other, research papers have shared, is that if you have a wide differential between the fasting and the post-meal sugars, right? Or the contribution of the post-meal sugar is very high to the overall HbA1c, then probably premix is a better choice, or a co-formulation insulin is a better choice compared to a basal insulin, right? So that's an essential argument. So to put that into formula, right, fasting blood sugar divided by HbA1c, if it's more than 20, there is more contribution of fasting blood sugar, so prefer a basal insulin. If it is less than 20, right, there are more contribution of a post-meal sugar to the overall HbA1c, in which case you should consider using a premix insulin, right? Again, remember these are mathematical terms. Your clinical practice would depend on your clinical practice. What I'm trying to do is trying to put it in a mathematical way, maybe, using these tools. Sometimes having algorithms makes your life simple because you don't develop decision fatigue, right? We all suffer from a condition called decision fatigue, right? We make choices for ourselves every day in the morning. When I wake up in the morning, what I'm going to wear, what I'm going to eat, everything, and then you go to work and you start making choices for your patients, right? What drug to give, what dose to give, right? We all suffer from decision fatigue. How do you reduce decision fatigue? Put things into algorithms, right? Makes your choice better. You put this in a system, right? It says premix is better, fine. Let's not argue, let's put the patient on premix. Let's not think, right? So sometimes algorithms are good because reduces this type of insulin fatigue, right? Okay, so let's look at a case, right? So again, just to show you the formula, we put these formulas all in the link which you had put. You can check it out as a mini application, right? You can check it out, right? So you can see that. Okay, so let's put this in a formula. So again, you have this values, and let's go back to the formula which was there, right? That is fasting blood sugar divided by HbA1c, right? And to make things simple, HbA1c is just 10. So 189 divided by 10 is, okay, so maybe basal insulin, right? You start, right? So this is where you take a basal insulin, okay? So these are again useful, right? Like I said, we put these kind of formulas in the mini application where you can use, okay? Moving on, then comes what dose to give, okay? So we decided the patient needs insulin. Let's say we decided patient needs basal insulin. What dose of basal insulin to give, okay? So, I think the dose thing is the fundamental question, because when Benting and Bess actually started with when they first developed insulin, the first question they asked, what dose to give, right? It's always true, right? That is an era before you had all the, fancy pharmacokinetics and dynamics and all the phase 1, 2, 3 trials, right? It was a human trial or animal trial, whatever that was, right? So that's the point. So what dose to give? That's an argument, okay? So let's again put a formula into a picture, right? Now there are two schools of thought, right? This is where I often differ from most, guidelines, and this is again going to be a expert opinion rather than a guideline based opinion. Most guidelines and most, remember this is, diabetes Asia study group, okay? So you're all probably traveling in the same boat, right? You're all probably facing the same problems. The problem is that most guidelines, if you see, guidelines, or even if you see the recommendations from the, insulin manufacturers themselves, generally it's 10 units. Start with 10 units, right? Or start some weight-based regime, which I find is probably incorrect. The reason why it's incorrect is that patients come to us in a more glucotoxic state, and patients come to us with a higher HbA1c at the time when you are initiating insulin. A global average is about 9%. Our average is 11 or 12% when we start initiating insulin, right? So we are starting insulin much later compared to, what others are doing. And in that regards, what happens is that when the patient comes, they're already glucotoxic, and sometimes that slightly smaller dose of insulin does not cut the cake, right? The patient's blood sugar doesn't get controlled. And then comes the question of the patient then questioning whether insulin is the right therapy or not, right? That's the challenge. And that's why Holman and Turner actually pegged the insulin dose based on the sugar values rather than based on the actual weight of the patient, right? And this actually makes more sense, right? In most situations, you give a dose of a drug on the severity of the disease and not on weight, unless it's of course pediatric age group, right? Most cases we always look at the severity of the disease and then you probably decide the dose of the drug, right? Now patient has a fasting blood sugar of 300. I really don't think 10 units is going to cut the cake, right? It's not. And this is the reality I'll tell you in clinical practice. Right? The glucotoxicity is not going to reduce, and patient will wait for a few days. Blood sugar is not coming down, you change the doctor. Tell me how many times this has not happened. It has, right? A patient will say, ek to mujhe insulin diya, right? Once you started insulin, that's not working. Why should I take insulin, right? So you have these arguments, right? So that's again real life situation. So Holman-Turner formula, very easy to use. Fasting blood sugar minus 50 divided by 10. So let's say your patient's fasting blood sugar is 250. What dose you will give? 20 units and not 10 units. And remember, this again fits with the fact that then you are going to monitor the patient and check their sugars. Because if you're not going to do that, start 10 units. That's again my personal recommendation. If your patient is not going to be compliant, then assess your patient's compliance, whether the patient is going to check the sugars, patient is going to titrate the dose of insulin. Only and only then consider this. Otherwise, you will actually end up with again more trouble, right? The other side of trouble, hypoglycemia, okay? So 38-year-old patient, right? Okay, let's, sure you got the point, okay? So, yeah, so this is the, let's say patient comes with you, this is a patient comes with 316. I'm sure you've all seen such patients like this in practice, right? Every day, one patient with 500 blood sugar, 400 blood sugar, right? Yeah. So my assistant who just started working with me since 1 year, sir, kitne patient aate 400 sugar wale? It's a daily thing, right? You will see it in books. It is surprising. In practice, this is a daily thing, right? It's a roj ka hai, right? So that is what happens. Okay. So 400 sugar, 300 sugar, 500 sugar, right? Very common. So this patient and this patient, whatever the weight of this patient, I'm sure 10 units is not going to make any difference. Right? So, yeah. So this patient, right, we started again a higher dose. You can again put this in the thing, and we have weight-based calculator also. Try putting some cases of yours in weight-based versus the Holman-Turner formula base, and you'll find that sometimes there is drastic difference in terms of the dosing. And then trust me, probably giving the other formula dose is probably better because the patient's blood sugar gets controlled much faster, and then that sense helps both patient and you. Okay. So then comes titration, okay? So you started insulin, now how do you titrate? Again, there is a school of thought here. So most guidelines, okay, anybody wants to volunteer? How do you titrate? So let's say you started a patient on 20 units of insulin. How will you titrate the dose of 20 units of basal insulin? Let's say basal insulin glargine, we started 20 units. Titration, how will you titrate?
Based on the fasting sugar levels.
Okay, so the dictum is fix fasting first, right? So you check the fasting sugar, and how will you, let's say patient comes to you next day, or patient reports to you next day, or after 2 days, that the fasting blood sugar is now 180. What will you do?
We'll increase the dose. We might need to wait for a day or so because the
Okay, let's say we waited for 4 days. Let's say after 4 days, patient says blood sugar is 180. It was 250. Yeah, so that's what guidelines say. Every 3 or 4 days, you increase by 2 to 4 units. Again, I differ here. I'll tell you why. That is again where glucotoxicity really comes into picture, right? So this is what I always used to do, right? See the fasting sugar, increase the dose if it's not in target, right? I'll tell you a pro tip, right? Again, expert recommendation. Works in a lot of ways. If you started a patient on X dose of insulin and the patient's blood sugar is coming down with that X dose of insulin, don't increase the dose. Glucotoxicity is anyway coming down, right? There is no hurry, there is no emergency. Take your time, right? Again, you start with a higher dose, right? But the counter argument in terms of titration is that I take it slow if the patient's blood sugar is coming down on their own, right? Or with the insulin, right? So let's say the patient's fasting blood sugar was 250, now it's 180, I'll not increase the dose. Continue 20 units, right? You can see in this, we do this with WhatsApp and you may do it in whatever ways you want, right? So let's say patient was 20 units. Now, when do I increase the dose or reduce the dose? The patient's blood sugar is increasing. Let's say patient is started with 200 and now it's 240. That means whatever dose you're given is not enough to curb the glucotoxicity yet. And then you increase the dose. So I say, okay, fine, you increase your dose to 24 units or whatever dose, right? If the patient's blood sugar starts going, so again the target, again most guidelines say target of 80 to 130. 80 to 130 is the usual target. I keep a target of 90 to 140, right? Not 80 to 130. 80 is little bit on the red side, right? And 130 again, so kind of shift it to about 10 milligram per deciliter. So if the patient's blood sugar is less than 90, I then start knocking a unit or two off, right? And if it's more than 140 and it's not coming down, right? If it's serially coming down, don't increase the dose. And once the patient lands into that sweet spot of 90 to 140, you just leave it with that, right? Keep checking for a few days, and if the patient is stable for about 3 or 4 days with the same dose, ask the patient to continue checking, but they'll just report to you if it's out of range, right? Otherwise, you can just keep it and then call the patient back on follow-up, and then you can then do the next step, right? So that's the whole idea in terms of titration, right? How do you titrate a premix insulin, right? So this is basal insulin, premix insulin. If you're giving once a day, premix insulin once a day, like the co-formulation insulin, again, little bit, variation, and this is what the manufacturer also apparently always wanted. The co-formulation insulin, which is very popular, Rhizodec, is, a lot of times I've seen it being prescribed twice a day, which is fine. It's fine. It's your practice in which you do. But I often recommend using it once a day, like a basal insulin, right? Use it like a basal insulin. And then if you do need a basal plus, if you need still additional, why not give a short-acting insulin instead of giving both the combination, okay? So my practice, what I do is if I start the patient on a Rhizodec, right, which is a co-formulation insulin, I start it like a basal insulin before the heaviest meal of the day. Let's say 20 units before dinner. Let's say dinner is the heaviest meal. And then you titrate it with the fasting blood sugar. And if it's, I have achieved the target, I'll just wrap it up. Right? Let's say I've achieved the target, fine. But let's say HbA1c is still high, and let's say post-lunch is high. Instead of splitting the dose, what I do is I add a short-acting insulin, a FIASP before the lunchtime. Now, why that is good? Because then I can independently titrate both the doses, right? If you give a premix insulin, if you give a combination, when you're increasing or reducing the dose, you're increasing or reducing the dose of both the components, right? And not one, which becomes very complicated. And one thing in insulin therapeutics, always remember this as a rule of dictum and as a rule of thumb, keep things simple. The simpler you keep, right? Why? Because at some point the patient will also start figuring out, okay, this is what you're doing. And then he'll start doing it himself, right? At least an intelligent one. And then he'll just stop bothering you, right? They're well managed, right? If you keep it too complicated, the patient does not understand how these things are being titrated. They'll always be dependent on you, right? And they'll have, paralysis of taking action on their own, and they'll end up in more trouble, right? Sometimes. And sometimes they take complicated decisions of their own, which is even more troublesome, right? So keep things simple. Sometimes explain to the patient that this is what we're doing. This is what our aim is, right? If the patient understands that, the patient will then start doing a few things on their own, right? For that one high sugar, they'll not bother you. They'll titrate the dose on their own, right? And correct it, right? So these are the whole idea, right? So I'll end here. I just have 37 seconds. On the system which we have put, it's there on the WhatsApp group. We also have additional things on storage about insulin and the transportation and other things which are frequently problems which a lot of us face. So you can check that out, right? And there are certain notes and applications also, so you can check that out as well. There is some material on the upcoming once weekly insulin also, so you can see that as well, right? We're happy to take a question or two if we have time. Yeah. I think it's now the break, so maybe you can take a question or two. Yeah. Yes, sir.
If you start basal insulin, what do you do about the sulfonylureas?
Yeah, great question. I think we should have addressed that. Yeah, so most of the time, right, if
People
a patient,
continue.
yeah, so they are the 6 milligram, and again, my rule of thumb, my algorithm is at that point of time, I cut the SUs by half. Okay. Whatever dose they are taking, I cut by half. So 6 milligram, I'll probably put him on a 2 milligram of SU and continue a basal insulin, right? Maybe then if I need to increase, I'll probably increase the insulin, right? So that is fine. One, again, rule of thumb, and you'll burn your fingers if you do that, don't stop the SU altogether, right? Don't, because you'll immediately so SUs, what they do is they keep, it's like a spring. They keep things under check, right? They keep it like that. And you take the spring out, right? You take that pressure on the spring out, it suddenly bounces back, right? And then again, patient goes into a glucotoxicity, and then again you are in trouble, right? And that becomes very difficult for you to control it, especially on an outpatient basis, right? Indoor patient, fine. Outpatient basis becomes very complicated. So it's why it's very useful that in OPD practice, I often then prefer, sometimes, we have a smaller dose, I prefer putting him in a glycoside, which is less hypoglycemia. So these are also few tricks of trade that you
But then
learn.
both do the same, like basal insulin and
Yeah, essentially yes,
Same.
because it's a long-acting SU, right? So a long-acting SU is like a basal insulin in all practical purposes, right? Yeah?
both-
Yes, please.
So right now you said that you don't consider increasing the dose of insulin as long as it is in the decreasing trend.
Correct.
You said if you have started at 250, now it's 180, you will not consider. For how long will you wait? If it is consistently 180 a number of times, then do you really?
Yeah, so that's a reduces. If it reduces, it's reducing.
If it is consistent at 180,
Then I increase the dose,
then you have
right?
to.
So if it is,
How long will you wait for that? How many?
yeah, so in my practice, in that initial titration phase, in my practice, again, it may differ on your practice, depending on your availability of resources. In my practice, it's daily, they have to report a fasting blood sugar daily to me, right? Now, when I say that patient's blood sugar is 180, next day it's 182, 183, I increase the dose. I don't wait, straight away I increase, right? But if the patient's blood sugar is 180, it's coming down to 177, 176, 175, it's reducing. I'm not touching it. I'm keeping it the same, right? And because it's reducing, maybe it'll some point it'll taper, it'll get sort of fixed again. It starts a little bit on the higher side again. Again, I increase 2 units or 4 units, right? So that's a simple, again, algorithm to do, right? Also has a safety balance built into it, if you see, right? Because if the patient's blood sugar is anyways coming down, you're not increasing the dose, you're keeping the same. It's an inbuilt safety system. Now, if you go by the standard guidelines, which they often say that you increase 2 to 4 units every day, then what you're doing is even if the blood sugar is coming down, the glucotoxicity is breaking, remember the patient will be on other therapies also, patient will be on an SU also, that's also working there, right? Now, breaking that down, right, at one point of time, let's say patient develops diarrhea, stops eating for a day, maybe has a Ramadan, and suddenly patient stops eating, and then patient ends up with hypoglycemia, right? But here you have a built-in check mechanism where you're not increasing the dose, right? So you're not, again, putting yourself in, shooting yourself in the foot. You're just monitoring it, right? So that's the whole idea. And then once the patient reaches a stable equilibrium, then I stop, patient can continue checking the sugars, but then they can stop bothering me, right? So that's the whole kind of plan. That you have that, that titration phase, you do a handholding, and then leave it to them. Yeah. Yes. Correct.
yes, sir.
$1 million question. So, yes. 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 Okay. So both, I'll answer both your questions. So, let's answer the second one, which is easier to answer. Glucotoxicity is still an abstract concept. There is no clear definition of it, right? So for that abstract concept, the answer is that glucotoxicity is when you have, blood sugars which are extremely high, which has started having some sort of acute issues because of the glucose itself, right? So patient developing unintentional weight loss, patient developing polyuria, with the very fact that the glucose itself, the patient is developing blood sugar. And what also it does is, when you have this kind of situation, it stunts the beta cell to some extent, becomes refractory, right, in that sense. And once unless the blood sugar starts coming down, that refractoriness doesn't go away. So it kind of lands up in a vicious cycle, where you have to then break the vicious cycle by putting. So we don't have any objective way. It's a clinical assessment which is based on your judgment, right? So when a patient comes to me, I'll tell you a typical example. A patient who has otherwise normal sugar now develops COVID-19 infection, blood sugar goes up, shoots up, 300, 400, right? And you know, whatever, earlier the same therapy was working, now it's not working anymore. That's classic glucotoxicity, right? So at that point of time, you break that glucotoxicity by putting the patient on insulin. Once it comes down, that same therapy starts becoming more effective. Asking, to answer your second question, which is again a common question, frequently asked question by a patient, kab tak lena insulin? How long do I have to take this insulin, right? Which is fair. No clear answer, it will depend on case to case basis. Okay? So let's say a patient has, you know, an acute situation like COVID-19, acute lower respiratory tract infection, a UTI, perioperative situation, and the patient's HbA1c was fine before that, not that high. Maybe then at some point of time you can go back to the previous therapy, right? And then taper it off and go back to the previous therapy. Patient comes with ketosis, then it's a red flag. Okay, so then what I will do is, now if the patient is fine on insulin, doing fine, okay with taking insulin, fine. That when the patient comes, then that is where I call the patient, right, and do a mixed meal stimulation test. If they find that patient is absolute insulin deficient, no question at all, the patient continues to be on insulin, right? At least from my side. Now, whatever patient wants to do, that's a problem, but my recommendation at that point of time will be, you need to continue insulin, right? However, right, if the patient has some residual beta cell function, or maybe it has improved. Remember, when your patient is in a glucotoxic state, the HbA1c sometimes may be, you know, the C-peptides may be very low, right? So again, you know, a lot of purists in that sense would argue that, you know, when the patient came with this situation, you should not have done C-peptide at all, which is probably true, right? But once now you are in a stable situation, calm water, at that point of time you do a mixed meal stimulation. If the patient has residual beta cell function, and then I'm not promising to the patient, but what I'm saying is that we can make some modifications to therapy, maybe then introduce a GLP, right? And then maybe then consider seeing if you can taper off the insulin, or maybe, you know, switch to other therapies if it's possible. Again, I'm also of the school of thought that an SGLT2 and GLP has intrinsic cardiovascular benefits, so these should be therapies for long term. So I then see whether I can put the patient on these therapies. But, you know, that depends on the case by case situation, right? So I say never promise to the patient that, you know, you will be off insulin, right? It depends on how it goes, you know, down the line.
So first patient, like what you said,
Yes.
You started him on insulin, patient sugars came down.
Yeah, so I think we'll take the last question and then we'll go, yeah.
The first patient, like you started on insulin, suppose the patient became online, HbA1c came to 7. So at that point of time, can we think of stopping insulin? And
Yes. So I would probably, right? If the patient is desirous, 30-year-old patient, I would probably consider, no, he can afford it. What I'll do is, at some point of time, I'll put him on a, you know, GLP, right? And then see how the insulin goes, and maybe we can reduce the, you know, maybe focus then on weight loss. This was unintentional weight loss. You would probably gain that weight again, and then start looking at the long-term picture, right? And start looking at the cardiovascular protection and other things. So yes, it is possible in first question. And that is exactly what we did. In fact, like he said, if you do a short-term, this type of insulin therapy, after some time the patient will, within couple of weeks, patient will be off insulin. So that is what will happen for this patient. This is exactly what happened. Yeah. I think we'll take the questions, remaining ones later. Thank you. And yeah, have happy learning.